Okay, guys, chapter 9 articulations, aka joints. So, joints are basically where our bones come together and where they're connected. The way they're made, both the structure of the bone and the type of joints, are going to give us a clue as to the range of motion, how that joint can move. So, here's a good picture showing some of these. That should be condyloid, not conoloid. Saddle joints, ball and socket. We'll talk about these guys coming up. Oh, that's a really good picture right there. X-ray showing a gymnast. Okay, classifying joints. We have the structural classification. We have the fibrous joints, which are bones that are united by fibrous tissue. These would be fibrous joints. Cartilaginous joints, obviously, are joined either by hyaline or fibrocartilage, these guys right there. And then we have the synovial joint. This is the most common type. The bone's not directly connected, but they've got ligaments that hold them together. But basically, we've got a joint capsule around here. And of course, you see the hyaline cartilage, the articular cartilage, and there's the ligament too, by the way. But these have synovial fluid in them that helps to lubricate. This fluid has things like chondroitin and hyaluronic acid, and these guys tend to be slippery, almost like a oil. Okay, as far as functional classifications, synarthroses, these guys are pretty much well immobile. They don't move at all. Amphiarthroses have a limited mobility. And then there are diarthroses, which are freely movable. Now, the diarthroses also come in a subdivision. You have the uniaxial diarthrotic joint, which the elbow is a good example. This guy can only move in one plane, basically like that. Elbow joints generally don't move side to side. Doesn't happen that way, nor do they move in and out. They can only move in that one plane. And that's why they're called uniaxial. Biaxial moves in two planes. The metacarpophalangeal joint. So the metacarpal bone is there. The phalange, the proximal phalange is there. You can move this guy, limited ability, side to side and back and forth. That's biaxial. Multiaxial moves in at least three axes. The shoulder and the hip joint, those have a great range of motion, especially the shoulder. Okay, continuing on. Our fibrous joints. No joint cavity. These guys are directly connected. Suture is one type of fibrous joint. There's fibers that connect the plates of the skull. Later on, they ossify and become bone, but usually not until later in life, 20s, 30-ish. And before then, there are actually membranes, suture or fibers that connect these two bones. We also have the syndesmoses, which are going to be these ligament fibers here connecting like the ulna and the radius, also between the fibula and the tibia. And that's basically called the antebrachial interosseous membrane, but it's a syndesmotic joint. So there's our suture, syndesmoses, parallel bones united, amphiarthrotic. Sutures are definitely synarthrotic. There should be no movement. Slight movement here because we know the radius is going to cross over the ulna like that when we rotate our wrist. And then the gomphoses, this is peg and socket, and this guy is tooth. tooth joint is going to be the gomphodic joint. Cartilaginous joints, hyaline or fibrocartilage, again, no joint cavity. So the pubic symphysis as well as the intervertebral joints are fibrocartilage. Dip epiphyseal plate before it ossifies is a cartilage joint that connects the epiphysis to the shaft of the bone. The costal cartilages connecting the ribs to the sternum is also going to be a cartilaginous joint using hyaline cartilage. Synchondroses, this is the type of joint we have here. Hyaline, temporary or permanent. This is temporary. The one connecting the ribs to the sternum is permanent. Symphysis, fibrocartilage, stronger, and also has different mobility, has a little bit more motility. Synovial joints. So this is not a real joint. This is just a generalized one, but you can see. So there are the bone ligaments. These guys are actually connecting these two together. A lot of times the capsule will incorporate the ligaments as part of it. And then we have in addition to this tough, dense connective tissue, we're also going to have, if you recall, a simple squamous epithelium in there, and we're going to have the fluid, the synovial fluid, which is basically an ultrafiltrate from the blood. In other words, we get the fluid portion of this from the blood. No cells, no red cells or anything. That's abnormal. And then, of course, we know the articular cartilage on the ends of the bones. And when these guys rub off, eventually wear off over time, that's when we get osteoarthritis. So the articular capsule forming the cavity, or the joint cavity. Articular cartilage, the hyaline on the ends of the bones. Synovial membrane, which forms the capsule itself and closes it. And then the synovial fluid. And all of these are diarthrotic. They are very, very mobile. Okay, we're actually taking a look at the knee joint from the side. So there's the femur and there's the tibia. Now, in addition to all these ligaments, this is ligament there, and there's this is actually a tendon, and this is the tendon that the patella kind of floats in front of the knee joint. We have a posterior cruciate ligament and an anterior cruciate ligament. I did those backwards. This is the posterior. It's also called the anterior cruciate ligament, ACL. It's named by what part of the tibia it joins. So the ACL starts on the back part, the posterior portion of the femur, but connects to the anterior portion of the top of the tibia. Patellar ligaments, and of course we've got the bursa. Bursa are synovial membrane, and they're fluid filled, but basically they're padding, they're cushions. So you have this, and you've got this fat pad in there as well for cushioning. There's another bursa right there in front of the kneecap. Here's another bursa up above the kneecap. And these bursa are, when they get overused and they get rubbed and they get inflamed, that's what bursitis is. And then, of course, the tendons of the muscle, which is the patella floating in. There's also on here, you can't really see it, so let me draw. This is the top of the tibia. You've got these pads of cartilage that are actually kind of C-shaped. And if you recall, looking at the femur, kind of has these um, condyles that are going to rest upon that. And it's just, those are called the meniscus or menisci. Okay, so the ligaments, we have extrinsic, which are totally outside the capsule. We have intrinsic, which are part of the capsule. And then we have intracapsular, which are totally inside. The cruciate ligaments, the ACL and PCL, are intracapsular. Some of the, you can't really see it because we're doing it from the side, but there's also ligaments that join on the sides. They're called collateral ligaments. Those would be intrinsic. And other ligaments are totally outside the capsule and not part of the capsule. Those would be the extrinsic. Tendons are the way that muscles attach to bones. So ligaments attach muscles to muscle, or excuse me, ligaments attach bone to bone, and then tendons attach muscle to bone. And in the meniscus, we've already talked about the bursi, which is the plural of bursa. Subcutaneous, between the skin and the bone. You get some that are submuscular, between the muscle and the bone, or between two muscles. And subtendinous is between a tendon and a bone. We need anywhere we have the possibility of something rubbing on the bone or on each other, we need a meniscus to be a padding. If you take, even though the ligaments and the tendons are very tough, if they constantly rub on the rough surface of the bone, eventually they will wear out. And then there's a tendon sheath, which is a special kind of bursa, and it looks like nothing more than a hot dog bun. And there's for the tendons of muscles that run through it just like that, guys. We talked about bursitis. We'll talk about some. We talked about his inflammation, pain, swelling, stiffness, housemaid's knee, or student's elbow. This, of course, is named because housemaids have to get on their knees to scrub floors and everything, and eventually the bursa get inflamed. And students, of course, is from leaning on a desk. There are other kinds of this. Well, let's talk about it. Overuse is very easily. Tennis elbow is a tendonitis. It's inflammation of the tendon, but kind of similar in function the way bursitis. They can be damaged by trauma, injury, excessive pressure, rheumatoid or gouty arthritis, or infection. I actually had an infectious tendonitis or bursitis of the elbow. What was it? Well, about a year ago. Very odd. Never had it before. Hope I never get it again. But it was actually caused by bacteria. Have no idea how they got in there. There was very little break in the skin. Oh, here's another, the Achilles tendon. How do you treat these guys? Well, except for the infectious, you rest it. You don't use the part. You can take ibuprofen or naproxen. These guys are anti-inflammatories. They'll take down the inflammation. You could get steroids from your doctor. And of course, for infection, you're going to take antibiotics. And they're showing you the bursa here. Different places that get inflamed. Okay, types of synovial joints. There's a lot of different synovial joints. It's based on the shape of the bones and how they actually come together. So right there between, if you guys remember, the axis C1 is basically a ring of bone. C2 is kind of a ring, but remember they have the dens that sticks up like that. And so if you look at it from the side, this is kind of what it looks like. So the ability of us to shake our head from side to side, like we do when we indicate no, makes this a pivot joint because it actually turns. There's also a pivot joint between the head of the ulnar and the head of the ulna in the proximal radio-ulnar joint right here. Now, as far as this joint itself, it's primarily a hinge joint because, as we say, this guy can go in this direction, and that's it. Cannot go side to side, cannot go back and forth. So this is a rotating joint, pivot, hinge joint, such as the elbow. It's going to go on that single axis. Saddle joint, this is between the first metacarpal and the first proximal phalange. Remember, that's the thumb. So we have a saddle joint, which is, as you see, is like two U shapes. Oh, I'm a terrible artist. Sorry, guys. Trying to do this with a minimum of. So we've got this one U-shaped, and then we have another U-shape that comes at an angle. You know, it's better just to do it this way. And this is the kind of motion we have. That's our saddle joint. You're going to find that at the thumb. Well, they're saying between the trapezium and the first metacarpal. That's not the way I heard it, but okay. Plane joints, these are like between the tarsal bones and also between the phalanges. These guys have got a limited ability to move back and forth and in and out. Not a lot of range of mobility, but it's there. And those are the plane joints. Sometimes those are called, I can't remember now. Oh well. Condyloid joints. These are going to be between the radius and the carpal bones. These guys are going to be like a very shallow bowl and have a round or oval shape in it. It gives you a little bit more mobility. It's going to be biaxial. Saddle is biaxial. Plane is multiaxial. No, the plane is really biaxial as well. I don't know why they put that. I disagree. Okay, so we got the hinge and we got the pivot. We know the pivot is uniaxial. Hinge is uniaxial. Ball and socket, this guy is for sure going to be multiaxial. He is going to be able to, here's one for the socket joint. It's going to be a deep bowl with a rounded head. So you can imagine this guy's got rotation capabilities. The shoulder joint is going to be the greatest mobility. There's a little, there's good mobility on the hip joint, just not as good as the shoulder because of the depth of the acetabulum. Arthritis, inflammation, swelling, stiffness, 100 different types. Now there's the degenerative type, osteoarthritis. See the bone spurs from where the bone has started to rub together because the cartilage itself has worn off. Basically, that's it. Cartilage has just worn off. Osteoarthritis, we're all going to get that. Well, that's just wear and tear. If you live long enough, you're going to get osteoarthritis. Because of the bone rubbing on bone, you're going to get inflammation, which means increased fluid, which is going to cause swelling and pain. Bone tissue, you get these deformities, these osteophytes or bone spurs. Gout is a special thing in which you get these crystals, and by crystals I mean like needle-like crystals. These are uric acid crystals from your body that, because of an overabundance of a certain type of nucleotide, you actually get this. This used to be something that only people who were very wealthy got because only they could afford to eat the kind of diet that would give you gout. So this would be like kings and nobles and people like that. Poor people didn't get this very much because they didn't have a chance to eat such a diet. Nowadays, we all have that chance, so we get it. In any case, these needles accumulate here, and for whatever reason, they almost always strike the hallux, the big toe. You can get this in other places. This is just kind of a characteristic sign. So these guys are there, inflammation starts, macrophages come in, swallow these things, and these guys are needle sharp on both ends, punctures that, and the whole thing starts over and over again. So you get an ongoing chronic inflammation in this area, very painful and very tender. Autoimmune diseases, scleroderma, and lupus, but probably rheumatoid arthritis is going to be one of the better knowns. Look at the deformity of these bones. These guys have had so much inflammation that what happens is between like the middle and the distal phalange, the joint goes away. That's one solid curved piece of bone right there now. You can see this, and that's characteristic. Rheumatoid arthritis often has this duck or swan's neck deformity. That's the end of the finger going back toward the hand. And it's, again, there's only one big long bone. There is no longer three phalanges there. Rheumatoid arthritis is caused by autoimmune. That means that you produce antibodies against your joints. It's obviously not right. It's a failure of the immune system. Very bad. There are treatments for it. Okay, the body movements. We did most of this in the lab, but I'm going to go over it again because not everybody's in the lab. So as far as the type of body movements, we have flexion and extension. So basically, I flex something. So say this is my arm. This is my elbow joint. If I move my forearm up here like this, that's flexion. Now, if you measure that, I can maybe convince you that that's 180 degrees. That's obviously a 90-degree angle. So flexion is when we decrease the angle of a joint. That's the definition of flexion. When I unbend it or take it back this way, that's called extension. Flexion and extension. And of course, now on between the thigh and the leg, you can see the same thing. There's 180 degrees, and you bring up the back, you bring your leg up behind you like this, you've decreased the angle. Now with the head, when we put our chin on our chest, that's flexion. When we return it back to the normal level, that's extension. When we move past the normal level backwards, that's going to be hyperextension. There's pronation and supination. So this is us in our normal anatomic position. This is the left arm. So you see the radius right there. And when you supinate, when you pronate, you actually turn, this is the back of the hand, you turn it over, and the radius actually is on the other side and crosses over the ulna. Okay, so there's pronation and supination. So pronation, if as you face front, you would see the back of someone's hand. Or if you're just holding it out to the side, it would be palms upward facing the sky, supination. Palms down facing the ground is pronation. Dorsiflexion and plantar flexion are things that only occur in the feet. Dorsiflexion is when you lift your foot off the floor, leaving your heel on there, pointing your toes skyward, dorsiflexion. When you press down like you were on a gas pedal on a vehicle, that's plantar flexion. The other thing, which is only with the feet, are inversion and eversion. So if you take, this is the left leg, if you take and you stand on the side of your foot, this side on the little toes, so that the sole of your foot is facing inward, that is inversion. Eversion is just simply the opposite. The sole of your foot faces outward. Okay, more extension and flexion. Abduction and adduction, abduction and adduction, or adduction. So if I take my arm and move it back toward the midline of the body, that is adduction, ADD. If I take that arm and move it outward, away from the body, that is abduction, abduction. If you rotate your arms in a circle like this, my gym teacher used to make me do that along with the rest of my class until it burned and burned and burned. That is circumduction. Rotation, of course, is when you move like your head from side to side, what we were talking about, what we do with the atlantoaxial joint. Now, with the arms and the leg, we have two types of rotation. Now, don't get this confused with inversion or eversion. I'm not just turning the sole of my foot, I'm turning the entire leg. If I move it outward like this, that is going to be lateral rotation. If I bring it back in toward this way, that is medial rotation. Protraction and retraction, if you jut your jaw outward past your upper lip, that is protraction. You bring it back, that is retraction. Elevation and depression, you get surprised and your mouth falls open, that's depression. If somebody takes your chin and closes your mouth for you, that is elevation. Opposition is simply what we do when we touch the fingertips to the thumb. That's why they call it an opposable thumb. Okay, selected synovial joints, the atlantoaxial joint, we've already talked about it. There's a ligament, of course, in there that gives a perfect circle that allows this guy to rotate. The TMJ joint, the temporal mandible joint, is between the mandibular condyle and the mandibular fossa of the temporal bone. Okay, glenohumeral joints between the humerus, the glenoid cavity, which is part of the scapula. Probably noticed that there's a very shallow cavity there, so that's what gives the shoulder joint such great range of motion. On the other hand, it also makes it a lot easier to dislocate. It's a lot harder to dislocate your hip because if you remember, the acetabulum is pretty deep. The head of the femur fits in there, but on the other hand, it has less range of motion. There's the elbow joint showing the olecranon fossa and the coronoid process. And you can see it, and there's the end of the humerus, specifically the trochlea, and this guy's fitting on it just like that. And of course, it allows us to go back and forth. There's that olecranon bursa near there, and there's another bursa up above it. There's the capsule around the joint. There's the olecranon process. There's all the ligaments that attach these bones together, and more of the same. Humero-ulnar joint, flexion and extension of the forearm. That's all you can do with it. That's why we say it's a uniaxial joint. Here's the hip joints as we were talking about it. The acetabulum, remember on the ilium, and well, the the coxal bone. The head of the femur fits in it very deeply. In addition to which, we have something called labrum. Labrum is another word for lip. It's actually dense connective tissue. So if that was the acetabulum, I would have dense connective tissue that kind of forms a lip on it that kind of grips a little bit further on the neck of the femur. There's all the ligaments that are consistent with it. A lot of the times when you hear about people who have broken their hip, these fractures oftentimes occur on the neck. If you remember when we had the bones, that is an area that takes a lot of stress. And there's the screws that the orthopedists use to fix that kind of thing. Okay, we're looking at the knee joint. So there's that tendon of the quadriceps. There's the patella floating in front of it. There's those collateral ligaments. One of them is named fibula because it's on the fibula side. You can also call that a lateral collateral ligament and medial. It doesn't matter. It's all the same. There's the C-shaped cartilage, the meniscus. One is going to be called lateral, which is going to be on this side. No, excuse me. This is a right leg on this side, and the medial is going to be on this side. You can see the ACL and the PCL. These have been cut, of course. You can see them in there. That's why they call them cruciate. They make an X form. This is the unhappy triad. This happens especially in football. When the leg is extended, it has to be extended because I didn't tell you this. I guess I better tell you this first. So there's the femur and there's the tibia. So the ACL is going to be taut when the leg is extended and the PCL is going to be floppy. But when you flex your leg, the ACL is going to be floppy and the PCL is going to be taut. So when people get hit from the side laterally, while the leg is extended, it will tear the ACL, it will tear the medial meniscus, and it will tear the medial collateral ligament. Why would it hit the medial? Well, think of it this way. Let's see if we just draw diagrammatically. It gets hit here, so the ACL is taut, so it gets torn. These guys, the ligament on this side are going to be the ones that are going to be put under this kind of pressure. So these are the guys that are going to tear. More synovial joints, talocrural joint. This is the joint that looks somewhat like that, in which the talus is there. It's going to be the joint that connects our feet with our legs. Again, there's that interosseous membrane I told you between the tibia and the fibula. And we have all these tibiofibular ligaments, talofibular ligaments. I mean, there's a lot of ligaments. Here's something about twisted ankles. If you do inversion or eversion past a certain limit, you'll get a tear in the ligaments. And those tears, extremely painful, and they do take a little while to heal. In addition to which, once you have stretched a ligament by tearing it like that, it will stay stretched and it'll be that much easier for you to twist your ankle again. Same thing with dislocating a shoulder. All right, guys, that's it for Chapter 9.